Good afternoon. Thank you all for coming. My name is Pedro Lemos, and I'm here together with people that do not have to be introduced: Bruno Scheller, Victor Alfonso Jimenez Diaz, and Antoinette Neylon. For, I'm sure, very interesting session from theory to practice, the versatility of drug-coated balloon around the world. I'm going to spend only 2 slides to show to you what's coming. There are several ways of introducing how much we are entering a new era, I think, for coronary intervention. That's going to be the DCB era. That's a way of putting this. For the next years, what's expected is to have phasing down of DES in terms of data and also in terms of penetration among us in the cath lab, things that we are doing, going towards more usage of DCB in the cath labs, not here in Europe, but also all over the places. So for this session, the objectives will be to learn more about the safety and efficacy of best investigated coronary DCBs, drug-coated balloons, in a variety of settings around the world, using DCBs with a data-driven treatment choice to explore how DCBs can reduce the complexity of the things that we do in the cath lab, PCI, to gain understanding on DCB coatings, paclitaxel and sirolimus, the 2 types of drug-coated balloons that we have currently in use and as an investigation type of device, to receive the latest clinical information of DCB use in de novo lesions, not only in central stenosis, and to get an understanding on how to use the hybrid approach, DCB plus stent in the same session, especially for challenging lesions to improve clinical outcomes. So without further ado, please, Bruno Scheller, come to the podium. Bruno will explain to us how was the history, current data, and established indications for DCB.
Thank you, Pedro, for this kind invitation. I'm also the spokesperson, and you have all the app of the meeting, and you can select this session, and then there's a button, Ask Questions, and we will get it to the iPad over there and can include it in our talks. So I'm getting old because I always have to talk meanwhile about history, and that's not a really good sign in my opinion. So this is the first slide. This is a paper which was presented in 1999 at the TCT meeting in Washington, D.C. And this was the first time I was allowed to attend such a big international meeting. And I was totally impressed from this presentation because they showed preclinical data in pigs with paclitaxel-coated stents. And most of the story that came up later on was in this presentation because they showed this dose-dependent effect in reducing neointimal formation if you apply drugs locally. And if you do too much, you get in trouble because there's not a significant healing. And this was very interesting. And we published in the same year, presented for the first time, data from our cath lab where we looked at the effect of contrast media on the outcome of PCI. And at this time, we had the non-ionic contrast media, which are standard today. And there was also an ionic contrast medium, which had anticoagulatory properties. And we found that this was better in our database and published it in the European Heart Journal. And the worst contrast medium was a non-ionic from Schering in Berlin. And they were not amused and invited me to have some talks about this publication. And the then head of R&D for contrast media was Professor Ulrich Speck. And he was very kind to me, or the other people also. And he was interested in how can we improve contrast media, which was because there was nothing new anymore at this time. And I was under the impression with this paclitaxel stent presentation from the TCT, and so we said, okay, let's try to use the contrast media as a tool for intravascular local drug delivery. And if you look, for example, at this right coronary artery here, after the injection of the contrast medium, you see a thin film staying there, and that was the idea to use this effect. And we started with cell culture experiments, vascular smooth muscle cells that were incubated either with short cell line and then the medium for their growth, or with such a contrast medium paclitaxel formulation. And we found that already a very short exposition of those cells led to almost complete inhibition of cell growth over up to 12 days. And this was the first experimental data showing that a short-term application could also work to a similar amount, like a controlled release of a drug. The next thing was to have a reliable animal model, and this was very important. And one of the people that helped me here was Hans-Peter Stoll, who's sitting here in the auditorium. And the model is that you implant bare metal stents with some controlled overstretch, and after 4 weeks you see the neointimal formation, and then you can test at the index intervention your treatment and look if this had some impact. And with this contrast media paclitaxel approach, we really saw a reduction of neointimal formation depending on the dose of the paclitaxel applied with the contrast medium. So at this time we had information from the stent research that controlled sustained release is able to reduce restenosis, but also with this short application for seconds with the contrast medium, it was possible to have a biological effect. And so the idea was born to do something in between, and I told Professor Speck, let's put it on a balloon. And he said, it's impossible to do so, but nevertheless it was possible, and these were the first prototypes. DCB, this is in the year 2001, what you can see here, and these were the first clinical samples which we used in the first man trial, which started in December 2003. Why does it make sense to apply drugs via balloon approach and not via stent approach? Because we have much more homogeneous drug distribution. And one of the important things which we may talk later on in the discussion between paclitaxel and sirolimus is that due to this homogeneous drug distribution, the peaks of the drug are much lower than it is the case if you apply them in a stent-based approach. Then the next important thing was that we realized it makes no sense to do the drug alone on the balloon. You need additives or excipients, as we say today. And this was the case here in this first animal study we did with where we implanted with our model bare metal stents, either with uncoated balloons or balloons with pure paclitaxel. And here there was no effect on neointimal formation, but the combination with the contrast medium led to dose-dependent reduction of the neointima after 4 weeks. But it's not only the excipient, it's also the coating procedure. You can see here the tissue concentration of paclitaxel over 1 month in the porcine model for the same coating composition, paclitaxel iopromide. But here in a crystalline form, where you have very good persistence of the drug in the vessel wall, here you see a purely amorphous coating with the same composition, where all the drug is lost after 28 days. But you can also create crystalline coatings that have a similar behavior as these amorphous coatings. This was the case here with very small crystals, less than 20 microns, in the Swide DCB, which is this DCB used in the Wreckage 3.1 trial. So it's clear you can do very different balloons with very different behaviors with the same excipient and same drug. When we had this animal data in 2002, beginning of 2003, the question was, can we translate this in the first in-man trial? And at this time, it was much easier to initiate a first-in-man trial than it is the case today. And we asked our local ethical committee, and they asked, okay, we trust you. They said, we trust you. And we were allowed to go in the indication instant restenosis, which was at this time an unmet clinical need because there were not drug-eluting stents available at this time. And the result was very clear. At 6 months, late lumen loss was reduced to almost zero with this experimental paclitaxel-coated balloon. And this is the very first patient worldwide treated in our lab with a drug-coated balloon. This was in January 2004. This instant restenosis in his right coronary artery, here the DCB, this was the initial result. And 6 months later, we had a good lumen still, very similar to the initial result. So I think this is very interesting when looking at the historical data. And this trial has been published in the New England Journal of Medicine in 2006, and is meanwhile seen as one of the milestones in interventional cardiology. I will come to the end, not going in all this clinical data we have. Meanwhile, one important lesson to learn was that it's not helpful only looking at specific devices. You have to rethink the whole therapy. And one of the most important things, in my opinion, in DCB development was to look more in detail on lesion preparation and start to focus with the research on this topic. The consensus group we created suggested this DCB only concept, where we do our very best with lesion preparation. And then the question is, do we have an acceptable result or not? And acceptable was defined as the absence of flow-limiting dissections and the diameter stenosis by eyeballing of maximum 30%. And then you can decide between DCB or DES. And my final slide are some historic pictures. This was in 2006, when we did our experiments. Here, Professor Speck in the middle, and this is the group from 2010. And most of the members of this group are still active. Thank you very much.
You see the impact of a technology when you are able to publish in the New England Journal of Medicine with 50 patients, right? So it's amazing. Pave the way in calcified lesions, how to use in a synergistic way DCB plus intravascular lithotripsy. That's the title of the talk. Those are my conflicts. We don't need a complex statistics to understand what's going on in the cath labs all over the places, and see that lesion and patient complexity is increasing as time goes by. This is a study that's almost 10 years now, and you see that, and it's increasing still. At that time, from every 3 patients in the lab, 1 had calcified lesion. It's actually increased now. So calcified lesions is something that you have to deal every single day in the cath lab. And when it comes to DCB, we know that adequate lesion preparation is key for good outcomes because it increases the efficiency of direct transferring to the vessel wall. It increases acute gain. It reduces the chance of acute failure and the need for stents. When you think about calcified lesions, obtaining good angiographic results only with balloon angioplasty in heavily calcified lesions is challenging. We all know that. And for calcified lesions, there is a tendency not to have the best scenario for direct transfer into the vessel wall because of the calcification. To date, no randomized trials have been conducted specifically for DCB in calcified lesions, and as a matter of fact, severe calcification has been excluded for many, if not most, randomized trials testing DCBs. Now, this is a simulation of a normal artery, a simulation in computers of how a balloon, as you inflate and put pressure inside of the balloon, how the balloon behaves inside of a normal vessel. It defolds, and in this specific model, you will have a complete inflation of the balloon at 2.5 atmospheres, touching the vessel wall in a homogeneous way. Now, if you put a calcium there, you will see that the touching of the vessel wall of the balloon is not complete, it's not homogeneous, and you may have a part of the vessel wall close to the edges of the calcification, and in this scenario here, you have a calcification nodule that is not touched by the drug by the balloon. So transferring of the drug to the vessel wall may not be complete in this scenario. Now, we do have to modify the vessel to accomplish good preparation, and if the vessel is a calcified one, you do not have many tools except by those that are plotted here in this cartoon. Plain old balloon angioplasty. You may use non-compliant balloons with high pressure, rod ablator, and intravascular lithotripsy shock waves. That's what we have right now. Now, if you think about the advantages and disadvantages of each one of these types of devices, you will find that IVL is perhaps the best companion for DCB because it's in the end of the day a balloon. So combining IVL for calcified lesions to prepare the lesion for a DCB may be the best scenario. Now, that's why we designed this small trial. It's an exploratory pilot trial, 2 centers, one in São Paulo, another center is in Verona. Flavio Rebicchini is the other co-PI of this trial. As I told you, 50 patients, only exploratory type of study. Calcification was defined in a normal way by fluoroscopy or by OCT or IVUS. We did exclude patients with bifurcations and acute lesions with thrombus, but other for that, basically all calcified lesions in small vessels were included. The primary endpoint is safety. This is basically a safety type of study, exploratory study. So patients will be assessed at 1 month for successful PCI. In the absence of complications, but we'll have these patients back to the cath lab for a secondary analysis at 6 months to be analyzed from an angiographic point of view and see the reaction of the vessel. So primary endpoint at 1 month, safety, and at 6 months secondary analysis for efficacy. 50 patients, we have already included 43 patients, so our expectations is to have this study presented next year here in EuroPCR. Let me give you one example, not of this study, but our current practice. LAD lesion, tight lesion, diffuse disease, calcification, as you can see here. We applied one shockwave 3.0 and then a DCB 3.0 in this patient. The side branch, diagonal branch is wide open there. And as you can see here, a good angiographic result immediately. This patient was brought back for other reasons, 6 months in the cath lab, and you see that you have the vessel is still wide open, and if you look at very closely, you will find that the vessel is actually even larger than it used to be just after the procedure. Now, in summary, because we only have 9 months, and I could show you more cases of that exact type of experience that we are having now in the cath lab, combining IVL with shockwave of IVL with DCB. We can say the calcified lesions are increasingly frequent. Coronary calcification poses a significant challenge to proper pre-DCB lesion preparation, and the synergy of IVL plus DCB is promising. We are investigating that. We think that in the near future we have more results to show to you. Thank you very much.
With Pedro, one question which you may answer now. There's the question: how do you choose IVL versus cutting balloon versus OPN and C before DCB treatment? Is there any differentiation?
In practice, we basically use DCB whenever the calcification is severe angiographically, and if you see a severe calcification in IVUS or OCT, even more. Then we go for a 1-to-1 balloon to artery ratio instead of less than that as a typical preparation for stenting. We try to do that 1-to-1, trying to achieve a good preparation for DCB instead of just a preparation for stenting.
If I may, what did you exclude the use of scoring and cutting balloon? Because as you just said, you need to prepare the balloon with specific and good size device. But for your study you just presented, it's an excluding criteria. That's a bit strange. Why? Just
for a pure scientific point of view. We wanted to test a pure DCB plus IVL type of scenario. In practice, very often we do cutting balloon or non-compliant balloon after DCB before the drug coating balloon. So in the trial, we excluded these patients because we didn't want to confound this confounder. But in practice, it's very common for us to do IVL, then complete lesion preparation with another type of balloon, non-compliant or cutting.
So in your algorithm, you go to IVL first, you don't use non-compliant.
Yep. Yes. Provided for the trial, provided it was severely calcified. There is no moderate calcification there, only highly calcified lesions. Okay, thank you, Bruno. Thank you. Yes. Antoinette, thank you. Current use of DCB in STEMI, Antoinette?
To be or not to be, or to go or not to go. That was the title I was given. So I'm going to go all Shakespearean on you. Don't worry. So DCB in STEMI, it's a very seductive idea, right? Because in STEMI, it could have a lot of advantages. We're faced with a large thrombus burden often in STEMI, so it can be very difficult for us to determine what the vessel size is. We're dealing with a lot of inflammation, so if we have an implant with a stent, that's going to aggravate the situation. We have impaired vasomotor function as well. That's going to have impact on vessel size. So all of this can lead to stent-related problems, which would include malapposition if we don't choose the stent size properly, and delayed endothelialization. And also in terms of the pharmacology for the patient, post-STEMI, we have questions around DAPT, the presence of a permanent implant that's going to really commit a patient to long-term DAPT. Patients who maybe are high bleeding risk and we don't know it when they present with STEMI, what do we do with those patients if they have a stent? And also the real world problems of intolerances and poor compliance when it comes to DAPT. And STEMI is a younger population, and we've seen this multiple times, but there are stent-related events, and they accrue year on year over the lifetime of a patient. So a young patient who has a stent implanted, they're going to carry a risk of 3% per year for the rest of their life of having an event related to that stent being there. So the absence of a permanent implant would, of course, be of particular interest. And going back to a little history lesson, well, we know that balloons work for STEMI, and though this is going back to balloon angioplasty that showed good outcomes in terms of mortality, but the problem was after 6 months, you're accruing TLR, so recurrent rates that are related to the balloon that doesn't have the capacity now to deliver the drug. So could a DCB close this gap for the POBA group? So that's a very seductive type of approach to these patients. So we've seen the importance of getting the drug from Pedros has told us that, we need to get the drug to where it needs to be. But of course, with STEMI, we're going to have a little problem of the thrombus that's being there, and that's going to be a barrier to delivering the drug. So that's something that we're going to have to also deal with. And this is something that started a long time ago, and there's been a lot of small single-arm data, but it's all very encouraging. And one of the first was going back to 2014, where we could see the single-arm trial of STEMI patients that were screened. And this is over 100 patients that were followed up for a period of 1 year. And we can see that there's a 40% bailout rate for the balloon arm. And over the years, we can see how really that has dramatically changed. But overall, we've had, pretty good primary endpoints in terms of about 5% rate of MACE for a STEMI population. So, in terms of outcomes, it's pretty comparable to contemporary STEMI populations. But what's really interesting in these patients is that the high uptake of thromboaspiration. So the idea that you've got to get the thrombus out of there, you have to adhere to the principles that you prepare the lesion correctly, and you want to get that less than 30% that diameter stenosis that Bruno related to, and then you apply the drug, and you can try and hope for these kind of results. So 2015, again, another group of paclitaxel DCB, again mandating thrombus aspiration, pre-dilatation with a 4% bailout and good 4.5% mortality at 30 days, again very comparable to contemporary STEMI populations. So this data has grown, and we have now some data in terms of a randomized controlled trial. So the Revelation RCT that was presented in 2019, which screened patients and randomized them to DCB versus DES. And they used an angiographic follow-up with physiology using FFR in terms of their primary outcome. And again, we've shown very comparable results for stents versus DCB in this population, and results that are maintained out to 5 years when the 5-year follow-up was published. So in other countries and other areas and other regions, there's a far more developed ethos when it comes to DCB, and this is Simon Ecclesall's group in the UK, where since 2016, the extremely early adopters of this Leave Nothing Behind strategy, where about 100, in 2016, there were about 100 STEMI patients being treated by DCB, and they gathered all of that data together, cumulative data in a propensity-matched group, looking at DCB versus contemporary stents, and we can see really very comparable outcomes for these patients. So that in this highly experienced group, that patients will do with the DCB have equal outcomes in terms of mortality, MACE, stroke, major bleeding, and this is in a huge cohort of over 400 patients where we have 5% bailout. These are not small vessels. These are large vessel patients that have been treated with a mean vessel size of 3.5 millimeters for both groups. Interesting, more bifurcations in the DCB group. So keeping it simple with the DCB strategy. Don't get into complex bifurcation, two-stent bifurcation stenting and STEMI. Use the DCB, and very comparable long-term results for these patients. So more recently, we've had, and we've mentioned to it as well, the RECAGE-2 study that was presented at the ESC last year. And I just think it's interesting because there was quite a lot of ACS patients in this study. For a real-world study, there were about 60% of the patients were acute coronary syndrome patients, with the 15% STEMI patients. And in that study, we didn't get the same results that we have had in other studies in terms of the device-orientated endpoints, where the DCB had performed less well than the stent. But I think it's interesting if we look at the population, only 3% of thromboaspiration, and we can see that in the other preliminary studies that I've alluded to, very high rates of thromboaspiration. So, I mean, still we have a lot to learn, and in terms of how to prepare these patients with a large thrombus burden in STEMI. So overall, the evidence regarding the role for DCB PCI in STEMI is scarce, but what we have is very encouraging. We have had some large retrospective groups that have been very early adopters that have shown equal outcomes for patients for DCB. And I don't know if we're really green light, but we're certainly not red light, so I'd say maybe we're amber light for these patient cohorts, and we look forward to more data on how to treat these patients in the future. Thank you.
Thank you, Antoinette. Perhaps we could spare some time in the end for the discussion. Let me remind you that we do have the space to have questions coming to Bruno through the app. Victor, you're next. Deciphering sirolimus efficacy, an OCT approach to understand clinical device performance. Victor Alfonso Jimenez Diaz.
Dear colleague, dear chairman, thank you very much for this kind invitation. To talk about the efficacy of sirolimus after DCB PCI, which is an important aspect to tackle. So nowadays, I think it's very well established that the use of imaging-guided PCI, either IBUS or OCT, during drug-eluting stent implantation, it's offer benefit to our patient population, mainly in those patients with complex lesion, left main disease, true bifurcation, long lesions. So in those population of patients, when you use IBUS or OCT, the incidence of events are lower. But when we talk about imaging-guided PCI using a DCB, we have less data still. So in the Ultimate 3 trial, the investigators uses an IBUS guidance that was associated with a lower in-segment late lumen loss, but also smaller diameter stenosis when you compare it with angio-only PCI at 7 months follow-up. And this is very important because you know that the residual percentage of stenosis after lesion preparation, and to try to reach DCB to vessel ratio 1:1 is key and are independent predictors to target lesion failure at 2 years follow-up. So let me walk you through a simple case to show you an OCT-guided drug-coated balloon angioplasty. This is a simple mid-right coronary lesion, a tight lesion in a stable patient. This is a basal angiography, the lesion to tackle. We did a baseline QCA analysis, 85% of diameter stenosis or 96 depending on the view that you use. And also the reference vessel diameter goes from 2.9 to 3.0. So if you use imaging-guided PCI, you will get a lot of information. Of course, you see that it's a tight lesion, but you dismiss all the calcium. There is not a calcified lesion. It's a fibrotic lesion mainly, as you can see here, but also you can get a very precise measurement of the vessel. So you can see that the vessel is 3.1 actually in this vessel. So it's around 10% bigger with the OCT than with angiography. So in base of that measurement, we choose to use for lesion preparation a cutting balloon 3.0 and then an NC balloon 3.25 nominal pressure. These were the result after lesion preparation, very good acute luminal gain and a small dissection. And if you assess your result with OCT, you can see this. You can see that the acute luminal gain was really nice, 3.1 millimeters in gain in the vessel, and the area is 6.2. So we were really happy with these results. We use a DCB now, sequence SCB 3.0, 10 atmospheres, achieving a final maximum diameter of 3.2 during one burst of 45 seconds. And these are the results, the acute results. So you can see a really nice angiographic results. Even if we are doing the final QCA analysis, we get a residual stenosis of 5%. But even the reference vessel diameter gets 2.7, 2.8, so pretty small. But going further, if you use an OCT after you finish your case, you can see that the maximum diameter that you gain is 3.3. So I think this is reassuring data. This is what we want to get or to obtain after lesion preparation in one simple case like this one. What about using IBUS in DCB? Well, IBUS gives us a lot of information regarding plaque composition, sizing, but also when you try to analyze paclitaxel or sirolimus efficacy with IBUS is kind of complex because the imaging that you obtain are not quite nice as an OCT. That you know, OCT has 10 times greater resolution compared to an IBUS imaging. So I will show you an example, another clinical example of a tight lesion in the distal right coronary artery. This is the baseline angiography. We treat this patient with a sequent SCB. This is the final result after the angioplasty, and this is the 1 month follow-up. So with good angiographic results after 1 month. But if we go further, we'll try to analyze the immediate sirolimus transfer and distribution. Just immediately after PCI, you can see this. You can see this drug particles all over spread in the vessel wall or in the segment that you are treated with your DCB. These particles are drug components, different sizes, different shapes. They transmit also this shadowing like stent struts behind the particles, so you can assess that you are delivering the drug in the vessel wall. But if you analyze this distribution, you can see different patterns of distribution. You can have a focal pattern distribution of the drug with 1 quadrant of the circumference of the vessel. You can find a segmental distribution that we call it when you see in 2 or 3 quadrants of the vessel these drugs in the vessel wall. And you can have circumferential distribution also, when you can see the drug all over the circumference of the vessel wall. So if you want to analyze the retention and persistent in vivo in these cases, well, we have some data also. You can trace where these particles go, and you can see that at 1 month you have the particles inside the endothelium. Just like a stent strut is endothelialized, is now in the vessels, stays in the vessel. It is similar to what we had seen in histological analysis of animal models published. What about 2 months? The drug stays there and is still going inside the endothelia and in the media. And what about 3 or 4 months? Well, this is another case, acute anterior STEMI of LAD occlusion. We treat this patient after lesion preparation with a sequent SCB. This is the acute result, a very nice luminal gain. And you see a 4-month follow-up. We even can see a late luminal enlargement with sirolimus. So the patient did fine. This is what we saw at the immediate after PCI with a DCB. This is small particles, bright particles, and behind the shadowing of the drug. And you can see the dissection after the DCB PCI. But at 4 months, you can still see the shadowing behind this segment that we treat with the drug. Potentially the drug is diminishing in brightness, but you can still see the shadowing and also the dissection and the clean endothelia. So in conclusion, there is no class effect among DCB devices, so each technology should be analyzed in separate trials. Lesion preparation is essential, as you know, to achieve optimal outcomes after DCB PCI. And of course, intracoronary imaging techniques should be used when appropriated, mainly to assess lesion characteristic of the patient that we're going to treat, to guide device selection for proper lesion preparation, and to correctly size the DCB that you want to use because you want to reach the endothelium, which is the target. So OCT is a valuable tool in research setting to assess immediate drug transfer, of course, but also persistence over time. Thank you very much.
Thank you, Victor. Our next speaker, Bruno Scheller again. The journey continues from paclitaxel to sirolimus. That's a question mark.
Sure, that's a big question at the moment. Is there a role for limus besides paclitaxel? I mean, we have all this fantastic data, meanwhile, for paclitaxel-coated balloons. I want to start with a remark about a discussion about cytotoxicity and cytostatic properties. Most people claim that paclitaxel is cytotoxic and sirolimus is cytostatic. Most of those things refer to this work by Vesely et al. From Munich from 2007, and they looked in cell culture on cytotoxic effects and apoptosis in vascular smooth muscle cells and endothelial cells. And you can see here, if you focus on cytotoxicity and the different drug concentrations, that it is true that sirolimus is very stable in its cytotoxic effects, independent of the drug concentration. So this is what people call a big therapeutic window. For paclitaxel, indeed, we see an increase in cytotoxicity with increasing drug concentrations. But if you look, for example, here at a tissue concentration of 10 nanogram per milligram, the cytotoxicity is almost the same as in the case with sirolimus. And the question is, with DCB treatment, are we in this area or are we in this area with paclitaxel? And I can tell you that we see within the first few hours tissue levels of about 100 nanogram per milligram with DCB treatment. That's true. But after 24 hours, we are clearly in this lower range where the cytotoxic effect being paclitaxel and sirolimus are the same. So therefore, I think this discussion about toxicity does not apply for DCB treatment. The next fundamental thing is how do both drugs work, how do both drugs interact with the cell cycle. The big advantage of paclitaxel is that we have an irreversible binding with the microtubes. This means if paclitaxel is in the cell is blocked and it will not divide anymore. And that makes paclitaxel a very nice choice for short-time drug application. In contrast, sirolimus has a very complex binding, reversible binding to the mTOR receptor complex. And this means at the end of the day that limus-coated balloons need a technology that more or less imitates the behavior of a controlled, sustained release from a drug over a longer time of period of time. And if you look at the tissue concentrations of different limus technology currently under clinical investigations, then you see that the drug transfer seems to be very good with all these different concepts. But if you look at 28 days tissue concentration, you see that there's a big difference between the different technologies. And again, our goal should be to have the highest possible drug concentrations in the vessel wall over a longer period of time. And so we have some negative trials meanwhile. Most of the trials compared the limus balloon with the sequin Please Neo, which is the standard in those trials for the paclitaxel-coated version. And one of those negative trials for the limus, in this case biolimus-coated balloon, was the reform trial published by Robert Byrne and colleagues, where they did not meet non-inferiority. And also for the Magic Touch, which has a reported sharp decline in tissue concentrations. Already at 2 weeks, there's almost most of the drug has already gone. And here again, we have the Transform 1 trial, which was negative, where Magic Touch did not reach non-inferiority against the sequin Please paclitaxel-coated balloon. But one very interesting finding comes also from Transform 1. If you look at the amount of dissection you created here, measured in dissection volume, we see a different behavior between this sirolimus-coated balloon and the paclitaxel-coated balloon. With sirolimus, we see an increase in late lumen loss with a higher dissection rate, which is typical for conventional angioplasty. In the paclitaxel-coated group, vice versa, we see a decrease with higher dissection volume of late lumen loss. So this means the more dissection you have with this paclitaxel-coated balloon, the higher efficacy is there in terms of reduction of restenosis. But there's also hope in the limus field. This is preclinical data we published years ago. We looked systematically at different formulations of sirolimus on the balloons, from totally amorphous coatings till highly crystalline coatings. And interestingly, this crystalline formation, highly crystalline formation with 4 micrograms per millimeter balloon surface resulted in tissue concentration in the vessel wall at 4 weeks of about 50% of the initial dose. And that's exactly what we need when we try to use sirolimus for drug-coated balloons. This has been shown by Victor very elegantly. This is the mechanism of action. We create here some deposits which then imitate sustained release into the vessel wall. This sequent STB has also been compared to the sequent Bliss neopaclitaxel-coated balloons in several randomized trials. This is the combined analysis of the Malaysian and European RCT in the treatment of in-stent restenosis, in total 101 patients. And here you can see the late lumen loss distribution at 6 months, which is almost the same for paclitaxel and sirolimus. We have meanwhile additional data from a Chinese trial, the Siplant ISR randomized trials, again comparing sequent Bliss neo with the sequent SCB. And here again we see very similar behavior at 9 months for late lumen loss for these two types of DCB. So mechanistically, at a shorter term follow-up, it seems to be possible to have similar results. We looked also on the treatment of de novo lesions, 70 patients in this Malaysian trial, again sequent Bliss neo versus sequent SCB. And here we saw very good outcomes, angiographic outcomes in both groups. However, late lumen loss was close to 0 with the paclitaxel-coated balloon, 0.10 with the sirolimus-coated balloon, and there was a significant difference in the frequency of late lumen enlargement. This means negative late lumen loss in favor of the paclitaxel-coated balloon group. And these results have been more or less confirmed in the European counterpart trial with the same design, which was published last year by us. Again, we see similar outcomes, but numerically some advantage of the paclitaxel-coated balloon. So this is the clinical program for this sequent STB sirolimus-coated balloon. We have this first-in-man randomized trials in Malaysia and Central Europe. We have the ISR trial, we have the Chinese ISR trial, and the two de novo trials. And ongoing is a large registry, all-comer population, which results will be available later this year. And now I want to announce a new trial project. It's called Basket Be All. It's the follower trial of the Basket Small 2 trial, which was focused on the treatment of small coronary vessel. And this will be an all-comer trial. And it will be a strategy trial. This means we will randomize the whole patient, either in a 100% stent strategy or in a DCB-only strategy with the sirolimus-coated balloon, in case the lesion preparation is successful. Otherwise, those lesions will all also undergo stent treatment, and it is planned to include almost 2,200 patients in this trial. So this is my conclusion slide. We have a reversible binding of sirolimus versus this irreversible binding of paclitaxel. So this means technologically it's more challenging to create a limus-coated balloon than a paclitaxel-coated balloon. For sure there is no class effect, so you have to look at each individual technology for these balloons. The question is, will we have differential indications for both drugs in the future? This is unclear. It seems to be that late lumen enlargement in de novo lesions is more a paclitaxel-specific effect. What we need now for limus-coated balloons are longer follow-up and trials powered for clinical endpoints. And for this specific crystalline coating with 4 microgram per square millimeter balloon surface, have we seen that it was non-inferior to the best investigated paclitaxel-coated balloon in terms of angiographic outcomes. Meanwhile, 500 patients are published from randomized trials, and more than 1,500 will follow from this large registry. And we are planning now this large all-comer strategy trial, Basket Be All. Thank you very much.
Thank you, Bruno. I think that we have 5 minutes to discussion. Antoinette, Do you think that with the data that we have right now, and perhaps in the near future, we are going to be able to use DCB as the workhorse for acute MI in the cath lab? Or this is going to be a niche type of device in this setting?
It's very hard to answer that question. I mean, it's as I mentioned, it's an extremely attractive idea. But I think, just in terms of STEMI, I think, we need to have maybe a standardized approach to these types of lesions that's a little bit removed from what we do with stents. Over the last few years, we've moved away from thromboaspiration as it's been downgraded in guidelines, and maybe it's something that we need to relearn. And if it's if we are going to apply this kind of treatment, because we have the problem of the barrier with the thrombus to getting the drug to where it needs to be, and also there are questions around. ACS, it's very heterogeneous population. We have patients who have high thrombus burden, have low thrombus burden. I mean, obviously, we would have concerns about no reflow, embolization. So maybe it's a little bit early to say, but I think what we've seen so far from the large registry data that's been published in the UK is extremely encouraging.
Interesting. To everybody, the mic is open. If you have questions, please speak out. Victor, I have a question for you. You have a lot of experience with imaging after DCB. Now I see people afraid of doing anything after DCB. Do you think that crossing the lesion again after having doing the DCB there, and then you go back with the IVUS of the OCT, do you think there is any type of possible disturbance of the drug delivery there? Can you scratch the vessel and decrease the chances of having the drug applied to the?
Definitely, I think that is a current doubt and fear that everybody has. So once you deliver the drug, you shouldn't touch nothing. So that is why we are conducting this type of research. So using the DCB in a proper way, get a really nice lesion preparation, see what is going on with the drug in the vessel wall, and then assess what is going on with the drug on time. So with our experience, I can tell you that the drugs stay there. There's a mechanism where the drug get attached to the endothelium, and it doesn't really matter in our experience, in our current series of patients. If you go there and see with an IVUS, you go there, go back there and see with an OCT, flushing back, the drug is not flushing away with the OCT. There is a fear of increasing dissections after DCB using OCT. Well, our experience is that is not happening. And also, there's coming a question of post-dilatation after DCB. Makes not too much sense to post-dilate something after DCB. You need to do a proper lesion preparation. But if, for instance, you have to come back and do post-dilatation for any reasons, our experience is that the drugs stay there. And most important, this patient has been followed up clinically and they don't come back. So that is the data I can tell you.
And do you use, because for sizing, so before DCB, before lesion preparation, okay. But do you have any way of using imaging after you have already prepared to check if it's okay or not, as you do with stenting?
I mean, you don't have to use OCT or IVUS in every case that you're going to use a DCB. Of course, this is for research purposes, and you have to rely on your measurements based on your experience, but also on QCA, knowing that you need to reach 1:1 or 1.2:1 vessel ratio, because you saw the example. It was pretty clear that the vessel was around 3, but in QCA it was 2.7, 2.8. So we need to lose this fear of getting a big dissection. We need to proper size the balloon with the vessel and do a proper lesion preparation. So we're using QCA imaging only in complex cases, complex scenarios.
Any questions? I think that we are very close. Bruno.
We have some questions from the app. so many of those questions have been already answered. They were about lesion preparation and the role of imaging, which is, I think, one of the things we have to look at. Other people are asking about the indication and guidelines. Is there any comment from you about guideline situation we have at the moment?
Well, the most important aspect of the guidelines that comes into my mind is the recent use of DCB or disappearance of the DCB used in stent restenosis. So we have discussed this in different platforms, and I think we need to get more information regarding the use and the safety of use DCB versus another metal layer after stent restenosis. This has to be taken case by case, and I think more data is coming with the new trials, with the new devices, with a better lesion preparation in stent restenosis, and after that to deliver the drug, and not with the current data that obtaining after this trial with potentially the lesion preparation was not optimal at that regard.
Okay, so I have the pleasure to close this session. We have learned from Pedro's presentation that lesion preparation in calcified lesions before DCB is possible, and IVL is a very promising approach for this topic, because we create channels that allow the drug to go to the deeper vessel wall. There is discussion still about the value of DCB in ACS patients, especially in STEMI patients. Our experience is also in line with what you presented. You have to get rid of the thrombus, and if it's possible to do so, then it makes a lot of sense, because you do not undersize a stent, which is frequently the case in STEMI patients. And I think, of course, we need more data on this, but it's a very promising indication. And then we have the long ongoing discussion about limus versus paclitaxel. Victor very elegantly showed you how you can look at it, how you can see what is happening, which is very impressive. And I mean, there are many more data coming up. One interesting thing will for sure the presentation of the solution trial by Simon later this year, I assume. What's also an emerging topic is really the role of imaging in lesion preparation in DCB treatment. And I was somebody who said, don't do imaging because you cross over to stenting in every case. But meanwhile, we learned a lot, and I think in the future, imaging will be one of the key components of our lesion preparation and DCB treatment. Okay, thank you very much for coming and for discussing.